All right, well, I think we'll get started. Good evening, everyone. Welcome to our February Neighborhood Health Series. I hope everyone's doing well. I'd like to thank Craig Fraley from Clark County Credit Union, who's here with us tonight, as well as Dr. Roberson, who will be our presenter this evening and our guest this evening. Thank you so much for being here. This is a really important topic. It's really one that's very close to my heart. The link has been made very clearly in terms of the importance of oral health to our overall health. And it's also clear that Nevada's children are not necessarily getting the primary preventative care that they need to stay healthy. I'm very proud of the work that Dr. Roberson leads at Roseman Dental and Orthodontics, and he'll be touching on that a little bit today. And with that, just let you know that we are recording this event, and this will be posted on the speakers.roseman.edu website, as well as the schedule for all of the upcoming events. And with that, I'd like to introduce Dr. Roberson. Dr. Roberson graduated from the University of Medicine and Dentistry of New Jersey Dental School as valedictorian in 2004. During his dental training, he was a recipient of many awards and a member of many honor societies. Following graduation from dental school, he completed a general practice residency program at Overlook Hospital in Summit, New Jersey, followed by a full-time associateship in Hillsborough, New Jersey. Dr. Roberson furthered his education by enrolling in the Orthodontics and Dentofacial Orthopedics residency program at University of Nevada, Las Vegas School of Dental Medicine. While there, he performed his duties as a resident, as well as numerous additional duties such as class president, course director, and teacher for the undergraduate orthodontics class, as well as a member of various committees. Upon graduation, Dr. Roberson honed his skills as an orthodontist by working as an associate at a practice in Reno, Nevada. In January 2010, Dr. Roberson joined Roseman as a full-time faculty member in the Advanced Education in Orthodontics and Dentofacial Orthopedics residency program. Today, he serves as the program's director. Dr. Roberson is currently an active member of the American Association of Orthodontists, Pacific Coast Society of Orthodontists, and American Dental Education Association. Thank you, Dr. Roberson, for being here, and I now will turn it over to you.
Thank you, Vanessa. It's an honor and a privilege to be here talking on behalf of Roseman University and the health seminars that you do and put all the effort to putting together. Tonight, we're going to be talking about the dental dilemma. Okay, but before we do, I'd like to take a moment to introduce Craig Fraley, the Director of Business Development at Clark County Credit Union, and offer a thank you for sponsoring this program. Craig?
Thank you. Good evening, everybody. As the health-filled credit union, we are proud to sponsor Roseman's Neighborhood Health Series. And if you ever want to be an owner of a financial institution and not just a customer, visit us at our website at ccculv.org or give us a call at 702-228-2228. And as an owner, you share in the profits at the end of the year. Thank you very much. And doctor, have a wonderful presentation, and everybody have a wonderful evening. Thank you.
Thank you. So what I'd like to begin with this evening is a chart that I'm sure you're all familiar with. Probably heard some things that heart disease is the #1 chronic condition in the United States. Well, yes, actually, in the past 15 years or so, it looks like arthritis has taken over as the #1 condition now that everybody's on their phones all the time, typing away, tablets, computers, and whatnot. But short of that, the leading condition has been heart disease, occupying around 11 to 12% of the population. That's something to be mindful of. Hundreds of medications are being produced to lower blood pressure. Even if we add in coronary heart disease, come on, they're very, very similar. We get numbers that top out to about 18 to 19% of the population. About 1/5 of the population suffers from some heart or coronary related disease. And so that's something definitely we should be taking notice of. However, if we look at active dental disease and percentages of worldwide population that has untreated dental disease, and that is cavities, looking at the United States, and this is in the high income United States, we can see that, those patients that do have access to care, and we're not talking about poor patients, we're not talking about patients that don't have access to care. We're talking about high income patients in North America, the United States, Canada, you know, a developed nation with incredible research capacity, incredible scientists, lots of funding. We've got a prevalence of untreated active dental disease that hovers about 22%. And this is one of the lowest in the world. Okay, we can see Australasia, you know, has a low percentage or a somewhat lower percentage, but even that's still 20%. Okay, if we go to Central Europe, the percentage there is almost 50% of untreated active dental disease. Okay, as a dentist, this is really disheartening to me. You know, in my training, we learn basically all the ways that we can put ourselves out of business, including water fluoridation, hygiene instruction, and yet still, you know, we're not suffering from a dental patient standpoint because all of these patients still have such untreated need. And I say this because, you know, we're all familiar with this current pandemic that we've been mired in for the past 2 years, COVID. You know, it's still going on, even though restrictions are being lifted, COVID is not going away. But in a matter of 2 years, we've come up with effective vaccines that can limit or eliminate, you know, the severity of the disease. Multiple different types of vaccines, not just one, mRNA, viral vector vaccines. The science is there, the research, the opportunities are endless, and yet we're still mired in what I would term a preventable pandemic. Okay, and that preventable pandemic is dental caries, tooth decay, as the lay people know it, just cavities. Okay, it's gone on far, far longer than any other pandemic, COVID, in history, and it's still going on, and there's no end in sight. And as I said, it's completely preventable, completely. Okay, Dr. Seuss said you only need to brush the teeth you want to keep. And again, as dentists, we've been coming up with ways to basically put ourselves out of business, telling patients to brush twice a day after every meal, floss twice a day, you know, rinse everything, fluoride in the water. The opportunities to get rid of dental decay, numerous, and yet again, it's still just is going on, and it affects all ages. It affects children, it affects adolescents, it affects adults. You know, it's indiscriminatory. It doesn't matter who you are, what age you are. It affects us all. Okay, the incidence of active decay over the lifespan, anyone from age 2 to 5, 28%, 12 to 15, 50% of the population has had some form of dental decay, 16 to 19-year-olds, 68%, 20 to 39-year-old, 87%, 40 to 59-year-olds, 95%, greater than 60-year-old. I don't know how it went down, but it's 93. You know, reporting, maybe people, as they reported, didn't have any teeth to say that they had dental decay. It affects all incomes, you know, whether you're employed or unemployed, in white collar, blue collar, rich, poor, you know, long-term ill or disabled, homeless. It affects us all, and certainly at various different rates. Money isn't everything, but it certainly helps. It affects all races. You know, we can see the effects on non-Hispanic white patients, non-Hispanic Black patients, Hispanics, non-Hispanic Asians. Untreated caries history. No one is immune to this. Okay, there is no protection. It affects us economically. Okay, we can see the economic impact of chronic diseases as it was measured in 2003. And cancer tops the charts. Okay, money's $319 billion. If you look up, you know, the total treatment expenditures coupled with the total lost economic output. Okay, money spent for cancer research worth every penny. Even as a dentist, I wouldn't question it. It's such a, you know, such a damaging disease. I've lost, you know, family members to cancer. And I can't imagine, you know, wanting to reduce any type of funding there. Over 5 times the treatment costs. Okay, not many people want to go back to work after treatment for cancer. It's exhausting. I can't blame them. Okay, but if we look at the economic impact of oral diseases, okay, $136 billion related to annual dental costs. Okay, with care, missed economic output. All right, admittedly, it's not as significant as cancer, but I don't know how many people I can say I could have prevented cancer. All right, yeah, there are some. You know, remember the graduation song in 1999, wear sunscreen? Yes, wear sunscreen, okay, but also don't smoke. But not many people you can say, you know, gee, I wish I could have prevented this leukemia. You know, cancer just, it happens as a matter of happening. It's highly unpreventable. But how many have said in their later years, I wish I took better care of my teeth? Okay, there's a lot of people that later on say, I wish I took better care of my teeth because they know that they could have done something then that could really affect them now. So if we take dental diseases and place it in the chart that we just had the opportunity to look at, okay, it's going to rank just below pulmonary disease and just above diabetes, 2 large, you know, conditions. But unlike all the others, the treatment costs far outweigh lost economic output. Why do we think that is? Okay, so if I took a poll of the audience here, you know, how many of us have had a toothache, but it doesn't really affect us until after 5 o'clock? Okay, now it's not a problem until after work when I have the opportunity to address it. And so many of these diseases, many of these problems that patients are having don't necessarily result in lost economic output because they're still going through their daily activities. You know, it's after the fact that they wind up having this discomfort and trying to seek treatment. Okay, when I was a GPR resident in 2004 and 2005, as Vanessa pointed out, in a small, you know, private hospital in a very affluent suburb of New York City, the #1 hospital call that I got from the emergency room doctors was a patient came in with a toothache. Okay, unfortunately, the ER doctors knew to medicate until we had office hours the following morning. Okay, but nobody wants to miss work for a dental appointment. So how did we get here? You know, how are we as, you know, patients, as practitioners, pointed the completely opposite direction of where dental care is? As I said, we as dentists are coming up with methods and materials and things to almost, you know, put ourselves out of business. And yet we're busier than ever. So if I were to take a poll as far as why people don't want to go see the dentist, I'm sure that many of you would fall into this, you know, one, if not more, of these reasons here. Okay, and #1 reason is cost. It's almost 3 times higher than what we typically associate the #1 reason that patients don't want to go and visit the dentist, and that because they're afraid. All right, look at me. Do I look intimidating? Do I look like someone who you should be fearful of? Over 50% of the students in dental school are females. Okay, they're not intimidating. My wife is a dentist. She's not an imposing figure. Okay, inconvenient time, we discussed that. Not many offices open after 5 or 6 p.m. I think if they did, they'd be very, very busy addressing these dental emergencies. Trouble finding a dentist, access to care, that's always going to be an issue. Okay, no original teeth. Well, clearly you don't, you know, need to go to the dentist too often when you don't have teeth. And so, you know, again, looking at cost, 3 times the next surveyed response of being afraid to go to the dentist. So money. All right, and so if we take a look at this slide, you can see what the average cost of treatment would be both with insurance and without insurance for different procedures. So for tooth cleaning, what the insurance companies deem to be a prophylactic, preventative, routine visit, insurance companies are generally willing to pay the entire visit. But if you didn't have insurance, you're looking at somewhere on the order of about $127 for that visit. Braces, which is where I operate on a daily basis, even with insurance, you're looking at an out-of-pocket cost of $3,407. If you didn't have insurance, about $5,000 or almost $5,000. Root canals, back teeth, front teeth, wisdom teeth removal, cavity fillings, dental crowns, surgical extractions, cosmetic gum repair. Cosmetic gum repairs are the same because, as it says, it's cosmetic. So many insurance companies don't address cosmetic issues. Veneers are another similar thing that a lot of insurance companies won't cover because it's entirely aesthetic. And then finally, gum repair, periodontal procedures. Those can be anywhere from $1,000 to $3,000 with insurance and upwards of $6,000 without insurance. Okay, so if you're not familiar with in-network and out-of-network or fee-for-service, the no insurance, in-network providers agree to a set fee from the insurance companies in exchange for what they believe is a never-ending list of patients, kind of like free built-in advertising. But there are definitely some savings to be had when you are in a plan as a patient. So a little closer here, average cost of dental procedures, extractions, cleanings, crowns, caps, if you will, veneers, implants, upper dentures, root canals. Okay, so kind of give you an idea of where these procedures fall in terms of the overall price of them. Now, if we look at the number of patients throughout the country that actually have insurance, we can see that these numbers have hovered typically around the 58 to 60%. But then all of a sudden, it seemed that we had a little bit of a spike all the way up to about 77 or 80%. Okay, many of which are commercial policies, and then some which are publicly funded, like Medicaid and whatnot. Okay, so if we look at the publicly funded options, we really start to see increases come around 2015. And if we take a look at that, well, why is that? Okay. In 2015, many states expanded their Medicaid eligibility due to Obamacare. And private insurances throughout that time pretty much remained constant throughout that time period. So a dental insurance plan, you can see that there's different levels of dental insurance plans. There's different maximums that the insurance plan pays out on your behalf. There's different percentages of each procedure that the insurance company pays out on your behalf. Okay, so copays can range from 0% for those preventative procedures like we talked about before, cleanings and x-rays and exams, all the way to only 50% for things like major restorative work, including bridges and crowns, as well as root canals. Okay, the area I work in, orthodontics, many plans don't even have coverage for that. You actually have to purchase an additional policy rider, if you will, to get orthodontic coverage. Okay, and even then, it doesn't cover the full cost of the procedure. Okay, non-renewing, one and done. So orthodontic insurance is a lifetime, once in a lifetime benefit. So if you do have it on your policy, you get to have your treatment and they bill your insurance company. But if you ever need to be retreated for any reason, and you're still on the same policy, you have no insurance coverage because you've used it already. So if we take a look using the previous slide, this slide, and its percentages that it's going to cover for your treatment, you can see that regular extractions often covered at about 80%. Your cleanings, as we said, are covered at about 100%. Your major restorative work, including all of these different crowns and veneers, and as I said, veneers may be covered. They may deem it to be a cosmetic procedure rather than a necessary dental restorative procedure, as well as your full upper dentures and root canals. Those are typically covered at 50%. So let's take a look at an example of what an average patient may need, for a missing tooth. So let's say a patient had a missing tooth. They want to do a bridge to restore that missing tooth so that, aesthetically, functionally. And so we look at each of these and we have crowns, one toward the end of the bridge, one toward the other end of the bridge, which we call abutments. Those are the crowns that seat on natural teeth. And then we have one tooth in the middle, artificial tooth called the pontic. Now, each of those crowns are about $1,100 each, which if we did the math from the previous visit are covered at 50%. Let's say one of those teeth needs a root canal because it's just been restored many, many times. It can no longer be restored by traditional methods. So you need to do a root canal and then finally a core buildup. And you can see what your total output without insurance would be, approximately $5,300. But you know that you have insurance, which covers 50% of that procedure. So factoring in your deductible, again, which is about 50%, I'm sorry, $50, you're going to be out of pocket about $2,675. And the insurance company is going to cover about $2,625 of that procedure. But we talked about the annual maximum. Okay, and the annual maximum is just how much the insurance company is willing to participate in your overall dental work. It's not like medical insurance where you meet a deductible and then everything else that you need for the remainder of the year will be covered, with only a copay present. So if we take a look and assume that we have a $1,000 annual maximum, we said that in theory, insurance should cover $2,625. You would pay $2,675, but that's wrong. Okay. Your insurance is only going to cover $1,000 of the $5,300, and you're going to be left on the hook for $4,300 of that. Okay. That's if they cover you at all. Many insurance policies actually have what they call a missing tooth clause. And that is when you join the policy, it's kind of like a pre-existing condition. So if you join the policy with this tooth already missing, they're not obligated to cover the procedure that's going to replace that tooth. They may cover the crowns that go on the adjacent teeth, but the tooth that's missing in the middle, they won't cover it. So you may even have to pay more than this because the insurance company has deemed that this is a pre-existing condition. They don't want to cover it. Now, what if we could break that down? Maybe do one of these crowns in this year and then another one of the crowns next year. Well, as a bridge, all of these crowns are tied together. So we can't separate those. And so we can only bill when the entire unit goes in together. So let's take a look at a family of four without dental insurance. If they had their annual premiums, well, they're not going to pay anything for dental insurance. They're going to have their preventative visits, about $1,400, so about $175 per cleaning and exam, with x-rays maybe 2 times a year, and then one filling for each, at $200. So the family of four without insurance is going to pay about $2,200. Okay, so let's talk about some insurance options. So the Affordable Care Act, Obamacare, required all health plans to include pediatric dental care as a defined essential health benefits. Adults, they weren't so lucky. So every plan for a minor had to have some level of pediatric dental care. But this is where it got complicated. Off-exchange plans had to have that coverage, but those plans that were deemed to be on exchange didn't need to include it if they offered a separate dental plan. And then purchasers could also waive the separate coverage. So the health plans that had dental benefits already included were almost like Bigfoot. They were believed to exist, but it was very difficult to find one. And the coverage, well, the coverage was really only preventative procedures, only including fluoride and oral health risk assessments. Cleaning, x-rays, and exams, they weren't included. So you got coverage, but the coverage was basically useless. Medicaid, this is another insurance option available for patients. And for Medicaid, it really just depends on where you live. If we look at Nevada, there's no dental benefits in Medicaid, or very, very little. Now, yes, children can get coverage, again, both under the Obamacare policies, as well as Medicaid. They get limited restorative. They may even be eligible for limited orthodontic treatment. But adults, they're not covered so much. I think they may only get the opportunity to get dentures. My wife deals with Medicaid all the time. I think they get dental dentures covered, but nothing else. Some states have really good coverage, extensive coverage here on the bottom, more comprehensive services, including diagnostic, preventive, and minor and major restorative procedures. But we're not in any of those states. Even Utah, with no dental benefits for Utah residents. Well, what about Medicare? Medicare is a medical plan that all individuals over, I believe it's age 65, get coverage for. Okay, but in terms of dental services, Medicare doesn't cover most dental care. Dental procedures or supplies like cleanings, fillings, tooth extractions, dentures, dental plates. Okay, Medicare doesn't cover anything unless it happens to be in hospital dentistry or in preparation for some type of major surgery. Okay, so your costs for Medicare treatment, if you have Medicare, is 100%. Medicare will pay $0. But wait, okay, at the time I was putting this PowerPoint together, there was actually some hope. The Medicaid or Medicare expansion that was initiated by Vermont Senator Bernie Sanders called for Medicare to cover dental benefits, preventive screening and basic treatment at 20%, and then major dental treatments at 50%. That was positive, okay? But this just in. The Medicare dental benefits is dead on arrival, okay? The Build Back Better program had the dental coverage removed from the bill, and there is no Medicare coverage for individuals or dental care. So the main gist of this is actually that dental insurance is not insurance. It's payment assistance. It helps offset costs, but it's not insurance. Okay, so let's stop calling it that. It's payment assistance, and it's limited at that. Okay, so if it's cost, then surely those who have insurance must use it, right? We're getting that benefit. Okay, why not use it? So here we can see the benefits of the top 5 insurance companies by subscribers. And the blue lines are the average benefits offered by the individual companies. You've got Delta, MetLife, Cigna, Aetna, and Guardian. Okay, but if you can't read that at the bottom, let me blow it up for you for a moment. Blue is average benefits. Orange is the average remaining at the end of the year. And the gray is actually the average that the insurance companies paid out on their policyholders' behalf. And so clearly you have the benefits, but they're not being utilized. According to Forbes magazine, what percentage of patients use their full dental benefit annually? And I'm going to kind of throw this out there to any of the participants who may wish to offer a suggestion towards this answer. So would anyone like to offer, take a guess as far as how many fully utilize their dental benefits on an annual basis?
And our guests can put this in the chat, or they can unmute themselves if they'd like.
Well, 3%. Only 3% of the population that has insurance utilizes their annual benefit on a yearly basis. All of that money that, sorry,
Dr. Roberson, 2 of our guests suggested 3%. So,
oh, okay.
There you go.
Congratulations. As a dentist, I would have even thought it was something higher than 3%. Honestly, that's just such a low figure. It completely blows my mind. I didn't expect it to be 71. I thought maybe 17 to 23% when I first saw it, but 3%. So, looking at that, where do we go from here? Well, it's kind of that triumvirate of demand, workforce, and economics that kind of identifies what the access is. So the workforce, well, that's going to be more dentists. The demand, well, will more people be going to see the dentist? and then the economics of which, what are the costs associated with this? So let's take a look here at a moment as far as access to care in the workforce. So on average, there's 61 dentists per 100,000 individuals in the United States. And this can range from a high of 104 in Washington, D.C. to a low of about 41 in Arkansas. Nevada, we sit at, somewhere around the middle in terms of the average. You can see the average, 61, 54.1 per 100,000 individuals. Not too bad. Okay, so is that workforce increasing or decreasing? Well, that depends on where you look. Overall, the United States saw a 2.9% increase in the dental workforce, with Texas, taking the gold crown at a 13.9% yearly increase. Idaho actually had an 8.7% decrease, and Nevada here at an 8.9% increase. So Nevada, is almost over three times the average for the United States. But does it matter? So let's take a look here further at Clark County. And this is the number of dentists per 10,000 population within, Clark County, Nevada, Metro Las Vegas, if you will. All right, and so we can see that there are various numbers, from 0.6 per 10,000 in the 89044 Southern Henderson area, all the way up to 92.2 in the 89191 zip code. Okay. So we have some zip codes as high as 92% and some as low as 0.2%. Right next to them at 89115, but nobody wants to be the competition or face the competition in 89191. And I know it's very difficult to see these numbers on the screen there. Okay, but if we look a little closer, we can see why the discrepancies in some of these counties. So let's break it down here. Here at the 89106, that has a 26.6 dentists per 10,000 population, but that's where UNLV Dental School is housed. So they have a lot of dentists that are faculty members at UNLV. And so their numbers are disproportionately high, especially relative to neighboring communities or neighboring zip codes there. If we look at the 89192 or 191, it's kind of difficult or fuzzy there. That's where Nellis Air Force Base is. And Nellis Air Force Base has a residency program that is a postgraduate dental education program, as well as military dentists that service the Air Force men and women and their families. Okay, if we look at the 89146, well, that's the College of Southern Nevada. They have the dental hygiene program, and they have to have dental faculty overseeing them, their treatment. So their numbers are disproportionately high because of that dental faculty. And then in the 89014 region, that is us here in Henderson, the Roseman University of Health Sciences, the orthodontic program, the AHD program. So we have dental residents that qualify under Nevada State Board as dentists. We have AHD postgraduate residents, dentists. We have dental faculty. So our numbers are fairly high as well. If we look at the 89134, which is on the western side in brown there, my guess is that just happens to be Summerlin, and that's where the money is. They're rich. So access to care, the demand. So under status quo, the national demand for dentists is projected to increase by 9% to 206,850 full-time equivalents in 2030. Roughly similar growth rates are also predicted in the demand for general dentists, 9%, oral surgeons, 7%, endodontists, 7%, periodontists, 11%, and other dentists is 12%. While the demand for pediatric dentists is 2%, and orthodontists, we're actually expected to decrease the demand, and that's because the population of children is decreasing as parents either delay having children or postpone it altogether. The annual birth rate is significantly decreased. And so orthodontists, we have a kind of a bleak future. Right, but overall, the dental market is expected to increase and the demand is expected to increase. And so if we look at that, access to care in terms of the economics, This is just a GDP per capita by US state. And we can see all the states in dark green and green, even down as low as the kind of yellowish. Right? And then we've got the orange, burnt orange and red states. Green states, they're wealthy, greater than $60,000 on a per capita rate. Okay, it's easy to see where the money is. And so if we superimpose this following chart with the dentist to population ratios across various states, it's easy to see that the dentists are flocking to the money. Okay, all these states that are in green on the left have higher rates of dentists per population as a result of it. And so our poor populations, their access to care is very, very low because many reasons, which we'll get into in just a few moments. But these maps almost mimic one another amazingly well. All right, so, again, on the access to care, 4,927 of the 6,319 dental health professional shortage areas are in rural or partially rural areas. And in those, there's approximately 24.3 dentists per 100,000 versus the urban areas, which have 36.7 dentists per 100,000. So there's 50% more dentists in these urban areas than there are in rural areas. And yet approximately 5 out of 6 of these DHPSAs are in rural counties. And so they don't have enough dentists to service their population. Why? Well, why the disparity? Well, number one, there's limited seats in dental school. There's only so many programs, and each program only accepts so many students per year. The rising cost of dental tuition. Student loan interest rates have skyrocketed. At latest, it's 6.28% for plus loans. The rising cost of loan interest. As you're a student, all that principal is garnering interest. All that interest is garnering interest as you delay or postpone your repayment programs. The desirability for living. Many students, many dentists want to live in desirable areas, these urban areas next to the coast, or that have these amenities for all the time that they wanted to spend in school. They want to have social lives. They want to go out. They want to, shop and have easy access to travel and cultural things. And then finally, retiring dentists. There's actually more dentists that are retiring than are entering the workforce. So our numbers are dwindling. Okay, so if we take a look at the average dental school debt, we can see that a bachelor's degree carries an average debt of about $29,000. Graduate school, that carries a loan debt of about $71,000. Parent Plus loan debts, about $29,000. Law school, one of the big three: law school, dental school, med school. Law school's debt, $145,500. That's a lot. Okay, it's, in some areas, that's a 3-bedroom house. MBA student debt, about $67,000. Medical school debt, $201,000. Pharmacy school, Roseman Pharmacy School, $180,000. This is not Roseman's pharmacy school students' debt. This is the average debt, for pharmacy students throughout the country. Nursing school, $20,000 for an associate nursing degree, $24,000 for a bachelor's in science and nursing, and almost $48,000 for a Master of Science in Nursing. Veterinary school, I was surprised to see that this one was as high as it was. $183,000 average debt for veterinary students. But again, the gold medal winner on the podium is dental school, $292,169. Almost 50% more than what a medical student is experiencing in debt. Okay, and depending on what you read, this one happens to say that the average dental student in the class of 2020 owes an average of $304,824 from their tuition. So I'm not sure if any of you have seen this article. It was published in the Wall Street Journal now about 2 years ago, if I'm not mistaken. Okay, Mike Maru has $1 million in student loans. How did that happen? Well, if you haven't had the opportunity to read this article, Mike Maru, like myself, is an orthodontist. He borrowed $601,000 to go to undergraduate, to go to dental school, and then to do his orthodontic residency. But as interest accumulated, he currently has $1,060,000 debt at the time of publishing of this article. Every day, his debt increases by $130. He's on an income-based repayment plan. So in 25 years, when the time span for his income-based repayment plan expires, that loan that's forgiven will be over $2 million. And his tax hit will be at least $700,000, depending upon where he lives. It could be greater if he's in one of the higher tax states, such as California or New York. Currently, he's in Utah. But that tax hit is going to be $700,000, and that you can't prolong. You have to pay that in that year. But he's still getting rid of a $2 million debt. But if we look at the math on it, his tax payment will actually be more than the amount he borrowed and the payments that he made. So it's a mess, admittedly. And I know that, there's all the talk about tackling student debt problems, that student debt is the largest form of debt currently. It supersedes mortgage debt, personal credit card debt, things of that nature. So how can we help? Well, Roseman University of Health Sciences, we have dental programs here in the state of Nevada and in the state of Utah that are designed not only to educate, but also to help to address the access to care dilemma as well as the cost dilemma. So a little timeline of the Roseman University College of Dental Medicine. In 2007, the College of Dental Medicine was formed in Henderson, Nevada. It was the inception of the orthodontic AEODO/MBA residency program, which took its first class in July of 2008. And then the first AEODO patients were screened somewhere around January of 2009, once full accreditation from CODA, the Commission on Dental Accreditation, came back and awarded the accreditation to the program. Then in 2011, the College of Dental Medicine in Utah opened, and their first class began in around September of 2012. Later on in 2017, we had the College of Dental Medicine consolidation, that is Utah and Henderson combined forces to be the Roseman University College of Dental Medicine. In 2018, the AEGD, or Advanced Education in General Dentistry, formed on the Henderson campus. And in 2019, that first AEGD residency or first AEGD residents began their program. And in 2022, just this month, the Cure for the Kids Clinic in Summerlin, in our Summerlin campus, opened the doors to their patients. So the mission of Roseman University of Health Sciences has been to College of Dental Medicine programs is to improve the oral health of the public with special attention to underserved people in the Intermountain West region by educating dentists, conducting educational and clinical research, providing on-site and community-based health services, as well as healthcare leadership. And it is this mission in which we really live by, as far as servicing our patients and educating our students and our residents. And so our programs here in Henderson, we have the Roseman University Dental Group Orthodontic Clinic, which is a 20-chair orthodontic clinic. We perform interceptive and comprehensive orthodontic treatment for children, adolescents, and adults. We treat patients with craniofacial anomalies, as well as patients that need surgical orthodontic pre-treatment and post-treatment. We use traditional braces, we use ceramic or invisible braces, we use lingual braces, as well as clear aligners. And then we do some adjunctive treatments as well, including TMJ disorders, sleep apnea, and some limited laser dental procedures. In addition, one of the areas that I kind of focus my own practice on is that of neonatal infant orthopedics, nasoalveolar molding, in which we take the segments of patients with cleft lip and palate, approximate them through pressures and tension, and allow for the surgeon to do a much better surgical or the patients have a much better surgical result after the treatment. So the patient that you see on the left was the patient prior to nasoalveolar molding therapy. And then the patient on the right is the same patient after nasoalveolar molding therapy. You know, if you look at the surgical procedure that's going to be involved to approximate the lip on the left, that's a very major procedure versus the one on the right, which is easy because of the proximity of the tissues. We also offer the General Dental Clinic over at the AGD program. And this is a multi-specialty dental clinic providing comprehensive dental treatment, including exam, radiograph, and cleaning, fillings, veneers, crowns, bridges, and implants, extractions and oral surgery, root canals, pediatric dental treatment, as well as dentures and gum disease. And then finally, just opening, I should say opening now, we just opened. At the time of the PowerPoint, we were opening soon. Up in Summerlin is our Cure for the Kids Foundation Dental Clinic. And they're going to be providing comprehensive pediatric dental treatment, exams, radiographs, cleanings, fluoride treatments, extractions, root canals, fillings, and crowns, and treatment for children with cancer and other medical conditions. So I want to thank you for taking the time out of your day this evening to listen to what we can do as dental practitioners to kind of offset the access to care issues, what the problems that we're facing, and finally to put an end to this preventable pandemic. So thank you for your attention, and I will turn it back over to Vanessa.
Great. Thank you so much. That was a wonderful presentation. I'd like to open it up to the audience. I think Dr. Thacker had a question earlier in your presentation, so I want to give him the opportunity to ask his question.
Certainly.
And Dr. Thacker, you can put it in the chat or you can unmute yourself if you'd like.
Sorry, that just took a second to figure out how to unmute there. But regarding the study that was posted there about the utilization of dental benefits, when they say that it was 3% of patients that utilized their full dental benefits, did that mean that they utilized the entire maximum, or did they use a certain portion of it? What exactly is the definition of full dental benefit there, I guess, is what I'm asking.
That was those patients that utilized the maximum benefit. So if they had $1,500 annual benefit on their insurance policy or insurance plan, they utilized the full $1,500.
Okay, perfect. And then just one more question, probably a little off topic, but regarding your work with the neonatal alveolar molding there.
Yes.
In the meantime, while that is actually going on, I mean, how is the infant feeding? Is there some kind of obturator you're using, or how do they actually maintain adequate feeding in that time period between then and surgery?
So amazingly, children or infants with cleft lip and palate actually find a way to feed, even though there is a hole connecting their mouth and nose. But the appliance itself, the nasoalveolar molding appliance, is an obturator, which has a nasal prong that extends from it to support the nasal cartilage as the tissues, soft tissues and the alveolar segments are coming together. So it does actually help them in terms of feeding because it produces an artificial palate for them in which they can then suckle on the bottle and the nipple and whatnot.
Oh, interesting. Thank you very much, Dr. Robertson. I appreciate the presentation. It was very good.
Oh, my pleasure. Thanks for the questions.
Are there any other questions from our guests?
I do have a question. Hi, this is Mary Faye. I'm a faculty in the College of Nursing, and I'm just curious about that study, the 3% usage of the full dental benefit. I could see that the public or the members of the insurance will utilize the benefits that has 100% coverage. because I have 3 children and I have to kind of figure out which one is gonna get the restorative services first, because it's like thousands of dollars. So I'm curious that the 3% is including the restorative services, because as we saw the slide, it only covers 50%. So if you have 3 children and each of them would have to go through a restorative dental services, and it's cost $5,000 each, which means that I have to fork out half of the 5,000 for the 3 children. So it would be interesting. And I'm thinking in the source of health promotion and encouraging the members to really utilize their dental benefit. But I want to utilize it, but I also have to make sure I have enough money to pay for that 50% copay.
Yeah. Again, it comes down to the overall cost of the procedure, and then really just what the insurance companies cover as a percentage of the procedure itself. For example, if you have a $1,000 annual benefit and you go and let's say you're getting a $2,000 crown, you still have to outlay $1,000 just to get that $1,000 coverage. So yeah, it is a lot. It comes down to utilization of the benefits. It comes down to actually having the benefits, but it also comes down to having the money to pay the copays. I agree.
Yeah, so when I know that my child is going to have that crown or the brace, then I sign up for the flex spending. So then it makes sense, because then I know that I'm going to spend this much. I might as well sign up for that for this year, for this calendar year. Yes.
Yeah, absolutely. And as I say, insurance, dental insurance is not insurance. It's simply just a payment assistance. Like we would expect that if we broke our leg, we would go to the hospital and, we would have a 20% copay. 80% of it is covered by your insurance until after you met your deductible. And so with this, you're still going to have a very large outlay, and you're really only covered to a certain percent. And then anything above that, you're on the hook for full cost. So if you had, if you utilize that $1,000 benefit at your first visit, and then something happened that you had to go again later in the year, the same calendar year, well, now you have no additional coverage. And so you're going to be paying 100% out of pocket for that procedure.
You have to wait for the next year unless you did it in October, November, and December.
Right.
Yeah, for the carryover. Yeah.
Yes.
Thank you so much for your presentation. Very, very interesting and thought-provoking.
Well, thank you.
Thank you, Marife. Any other questions from our guests? Okay. Well, thank you so much, Dr. Roberson. This was a fantastic presentation. Thank you to our guests. And we will have this recording posted on the website. And we look forward to seeing you next month. Thank you all. Stay well.
Thank you.
Good night.
Have a great night.